Morning class. So today we're going to be going over Chapter 34, Pediatric Emergencies. Special patient populations applies a fundamental knowledge of the growth, development, and aging and assessment findings to provide basic emergency care and transportation for a patient with special needs. Patients with special challenges, recognizing and reporting abuse and neglect, healthcare implications of abuse, neglect, homelessness, poverty, and bariatrics. Technology dependent, hospice, terminally ill, tracheostomy care, dysfunction, home care, sensory deficit loss, developmental disability. Pediatrics, age-related assessment findings and age-related assessment and treatment modifications for pediatric-specific major diseases and or emergencies. Upper airway obstruction, lower airway reactive disease, respiratory distress, failure arrest. Shock, seizures, sudden infant death syndrome, or SIDS. Age-related assessment findings and developmental stage-related assessment and treatment modifications for pediatric-specific major diseases and or emergencies, upper airway obstruction, lower airway reactive disease, respiratory distress, failure arrest, shock. Seizures, sudden infant death syndrome, GI disease. Trauma applies fundamental knowledge to provide basic emergency care and transportation on assessment findings for an acutely injured patient. Special considerations in trauma, recognition and management of trauma in pregnant patient, pediatric patient, geriatric patient. Pregnant patient, pediatric patient, geriatric patient, cognitively impaired patient. Children differ anatomically, physically, and emotionally from adults. Illnesses and injuries that children sustain and the responses to them vary based on age or developmental level. Important to remember that children are not small adults. Fear of EMS providers and pain can make the children difficult to assess. Once you learn how to approach children of different ages and what to expect while caring for them, you will find that treating children also offers some very special rewards. Communication with the patient and the family. When caring for a pediatric patient, you must care for parents or caregivers as well. Caregivers often need emotional support. A calm parent usually results in a calm child. An agitated parent means child will act the same way. Remain calm, efficient, professional, and sensitive. Growth and development. Many physical and emotional changes occur during childhood, birth to age 18. Thoughts and behaviors. You guys should know the different stages of growth development from infancy, toddler, preschool, school age, and adolescent. The infancy is defined as first year of life. First month after birth is neonatal and newborn period. 0 to 2 months, spend most time sleeping and eating, sleep up to 16 hours per day. Respond mainly to physical stimuli, cannot tell the difference between parents and strangers. Crying is one of the main modes of expression. 0 to 2 months, basic needs, food, warmth, and comfort. Soothing includes holding, cuddling, or rocking. Hearing is well developed at birth. Calm, reassuring talking is helpful and soothing. Have a sucking reflex for feeding. Head control is limited. This is why we place our hands behind the patient's head at this stage. Their neck muscles aren't strong enough to keep their head up. Predisposed to hypothermia. Remember, children very young and people very old have a tough time regulating their body temperature. May need to unbundle the infant during assessment. 2 to 6 months, more active at this stage, easier to evaluate, spend more time awake, smile and make eye contact, and recognize caregivers. Have strong sucking reflex, active extremity movement, and vigorous cry. May follow objects with eyes. Increase awareness of surroundings. Will use both hands to examine objects. About 70% of infants will sleep through the night by 6 months. Begin to roll over at this stage. Persistent crying, irritability, or lack of eye contact can be an indicator of serious illness, depressed mental status, or a delay in development. 6 to 12 months, infants begin to babble, say their first word by their first year, learn to sit without support, begin to crawl and finally walk. Predisposes age group to increase exposure to physical danger. Begin teething and exploring their world by putting objects in mouth. Higher risk of choking and poisonings. May cry if separated from parents or caregivers. Called separation anxiety. Assess with caregiver nearby. Persistent crying or irritability can be symptoms of serious illness. Assessment: observe infant from a distance. Caregiver should hold baby during physical assessment. Provide sensory comfort. Warm hands and end of stethoscope. Do painful procedures at end of assessment. The toddler: after infancy until 3 years of age, a child is called toddler. Experience rapid changes in growth and development. 12 to 18 months, begin to walk and explore. Able to open doors, drawers, boxes, and bottles. Because they are explorers by nature, not afraid, injuries increase. Begin to imitate behaviors of older children and parents. No major body parts. May speak 4 to 6 words. May not be able to fully chew food. 18 to 24 months, mind develops rapidly at this stage. Vocabulary increases to about 100 words. Able to name common objects. Begin to understand cause and effect. Balance and gait improve rapidly. Running and climbing skills develop. May cling to parents or comforting toy. Use any comforting objects when available. Assessment: may have stranger anxiety. So make sure you get down on their level and see them. May assist separation from caregiver. May have a hard time describing pain. Can be distracted. Begin your assessment at the feet. Remember, for any other patients, we're head to toe assessment. For younger patients in this age, toddler, you're going to do from toe to head assessment. Persistent crying can be a symptom of serious illness or injury. Previous medical experience may lead you to hesitation toward you. Preschool-age child, age 3 to 6, able to use simple language effectively. Most rapid increase in language occurs at this period. Can walk and run well. Begin throwing, catching, and kicking during play. Toilet training is mastered, having a rich imagination, and can be fearful about pain. They believe injury is a result of earlier bad behavior. So make sure to reassure the child that it's nothing that they did wrong. Learn which behaviors are appropriate and inappropriate. Foreign body aspiration, airway obstruction is still a high risk. Assessment: can understand directions and be specific in describing painful areas. Much history must still be obtained from caregivers. Communicate simply and directly. Appealing to child's imagination may facilitate examination. Never lie to patients. Patient may be easily. Begin assessment at feet. Moving to head. Use adhesive bandages to cover the site of an injection or small wound. Modesty is developing. Keep child covered as much as possible. School age years, 6 to 12 years, beginning to act more like adults, can think in concrete terms, can respond sensibly to questions, can help take care of themselves. School is important. Children begin to understand death. Assessment begins to be more like adults. To help gain trust, talk to the child, not just the caregiver. Start with the head and move to the feet. If possible, give the child choices. Ask only the type of questions that let you control the answer. Do not bargain or debate with the patient. Allow the child to listen to his or her heartbeat through the stethoscope. Can understand the difference between physical and emotional pain. Provide simple explanations about what is causing their pain and what will be done. Ask the parents or caregiver's advice about which distraction will occur best. Adolescents, 13 to 18 years, able to think abstractly and can participate in decision making. Personal morals begin to develop. Able to discriminate between right and wrong, able to incorporate values into decision making, physically similar to adults, shifting from family to friends for support, interest in romantic relationships begins. 12 to 18 years, puberty begins, very concerned about body image and appearance, so let them have some privacy. They have strong feelings about that. Time of experimentation and risk-taking. Often feel indestructible, struggle with independence, loss of control, body image, sexuality, and peer pressure. May have mood swings or depression. Assessment can often understand complex concepts and treatment options, allow them to be involved in their own care, provide choices while lending guidance. EMT of same gender should do physical examination if possible. So remember, anytime you have a woman or a female, you want to try and get another female to assess them. So allow them to speak openly and ask questions. Risk-taking behaviors are common, can ultimately facilitate development and judgment and shape identity. Can also result in trauma, dangerous sexual practices, and teen pregnancy. Female patients may be pregnant. Important to report this information to the receiving facility. Adolescent may not want parents to know the information. Try to interview without the caregiver parent present. Just take them in the back of the ambulance. Give them a little more privacy. Ask them one-on-one. Is the patient sexually active? That answer is yes. Then you're going to ask when the last period was. If the patient tells you no, they're not sexually active, then you don't have to worry about pregnancy. Have a clear understanding of pain. Get them talking to distract them. Anatomy and physiology. Body is growing and changing very rapidly during childhood. You must understand the physical difference between children and adults and alter your patient care accordingly. So the respiratory system. Anatomy and airway differs from adults. Pediatric airway is smaller in diameter and shorter in length. Lungs are smaller, heart is higher, and child's chest. Glottic opening is higher and positioned more anteriorly, and neck appears to be non-existent. As child develops, the neck becomes proportionally longer as the vocal cords and epiglottis achieve anatomically correct adult position. Larger, rounder occiput, proportionally larger tongue, long floppy U-shaped epiglottis. Less developed rings of cartilage in the trachea, narrowing funnel-shaped airway. Diameter of trachea in infants is about the same as a drinking straw. Airway is easily obstructed by secretions, blood, or swelling. Infants are nose breathers and may require suctioning and airway maintenance. Respiratory rate of 20 to 60 breaths a minute is normal for a newborn. So remember, take a look at your pinky. That's how big your trachea is. And think about a kid or a baby. Think about how big their pinky is. That's how big their airway or their trachea is. So that's why it's very important to monitor their airway and see if the patient's swallowed anything, any foreign objects. Children have an oxygen demand twice that of an adult, increases risk for hypoxia. Muscles of the diaphragm dictate the amount of oxygen a child inspires. Pressure on child's abdomen may cause or can cause respiratory compromise. Use caution when applying the straps of a spinal immobilization device. Gastric distension can interfere with movement of the diaphragm and lead to hypoventilation. Breath sounds are more easily heard in children because of their thinner chest walls. Destruction of poor air movement or complete absence of breath sounds may be more difficult. Circulatory system. Important to know normal pulse ranges. Infant's heart can beat 160 beats a minute or more. Primary method to compensate for decreased perfusion. So remember, the smaller the child, the more their heart rate's going to beat. And as you grow older, the heart rate's going to slow down a little bit. So children are able to compensate for decreased perfusion by constricting the vessels in the skin. Blood flow to the extremities can be diminished. Signs of vascular constriction include pallor, early sign of weak distal pulses in the extremity, and delayed capillary refill, and cool hands or feet. So here's your table of pulse rates. So newborn to 3 months, it's going to be up in the 85 to 205 range. 3 months to 2 years, 100 to 190. 2 years to 10 years, 60 to 140. And then over 10 years, it kind of goes down in that adult range where it's going to stay the rest of their life, 60 to 100 beats a minute. So the nervous system, pediatric nervous system, excuse me, is immature, underdeveloped, and not well protected. Head to body ratio is larger. Occipital region of head is larger. Subarachnoid space is relatively smaller, leaving less cushioning for the brain. Brain tissue and cerebral vasculature are fragile and prone to bleeding from shearing forces. So remember, an infant's head is going to be a lot heavier and bigger compared to in proportion to the rest of their body. So when a child falls, they're most likely going to fall on their head because that's going to be the heaviest part of their body. Pediatric brain requires higher cerebral blood flow, oxygen, and glucose. At risk for secondary brain damage from hypotension and hypoxic events. Spinal cord injuries are less common. If injured, it is more likely to be an injury to the ligaments because of a fall. For suspected neck injury, perform manual inline stabilization or follow local protocols. Gastrointestinal system. Abdominal muscles are less developed, less protection for trauma. Liver, spleen, and kidneys are proportionally larger and situated more anteriorly and closer to one another. Prone to bleeding and injury. There is a higher risk for multiple organ injury. Musculoskeletal system. Open growth plates allow bones to grow. As a result of growth plates, children's bones are softer and more flexible, making them prone to stress fracture. Bone length and discrepancies can occur if injury to growth plate occurs. Immobilize all strains and sprains. Bones of an infant's head are flexible and soft. Soft spots are located at front and back of head, referred to as fontanelles, will close at particular stages of development. Fontanelles of an infant can also be used as a useful assessment tool. So if you guys ever held a baby, you see depressed parts of their head. Those are fontanelles. You usually see them in the back of their on the back side of their head. The thoracic cage is highly elastic and pliable, composed of cartilaginous connective tissue. Ribs and vital organs are less protected. The integumentary system. Pediatric system differs in a few ways. Thinner skin and less subcutaneous fat, which means they're less able to regulate body temperature. Composition of skin is thinner and tends to burn more deeply and easily with less exposure. Higher ratio of body surface area to body mass leads to larger fluid and heat losses. Scene size up. Assessment begins at time of dispatch. Prepare mentally for approaching and treating an infant or child. Plan for pediatric size up, equipment, and age appropriate physical assessment. Collect age and gender of child, location of scene, NOI or MOI, and chief complaint from dispatch. Scene safety. Ensure proper safety precautions, standard precautions. Note position in which patient is found. Look for possible safety threats. Patient may be a safety threat if he or she has an infectious disease. Do an environmental assessment. Will provide important information. Inspect physical environment. Information from parents or caregivers is important and may provide clues to the patient's problem. Document dangerous scene conditions and inappropriate statements from caregivers. Traumatic scene where the child is unresponsive or too young to communicate. Assume the injury was significant and enough to cause head or neck injuries. So remember, if anybody's altered, GCS less than 15, less than a perfect score, you're going to C-spine everyone if they've suffered a traumatic event. Perform cervical spine immobilization if suspected MOI is severe. Pat under the child's head and or shoulder to facilitate a neutral position for airway management. Form a general impression. Use pediatric assessment triangle or PAT. Does not require you to touch the patient. Can be performed in less than 30 seconds. So remember, when you're walking up on scene for any and every patient, you're doing a general impression. You're looking at how the patients, their work of breathing. Do they look like they're in respiratory distress? What's their appearance like? What's their skin color? Do they look pale? Do they look cyanotic? And then circulation to skin. You could also go ahead and touch their skin. Check their pulse. Make sure they're getting good perfusion. And what does their skin feel like? Does it feel warm? Does it feel cold? So PAT does not require equipment. 3 steps: appearance, work of breathing, and circulation. Appearance, note level of consciousness or LOC, interactiveness, and muscle tone. You use the AVPU scale. Modified as necessary for the pediatric patient's age. Normal level of consciousness. Act appropriately for age. Exhibit good muscle tone and maintain good eye contact. Tickles mnemonic helps determine if the patient is sick or not. Tone, interactiveness, consolability, look or gauge, speech or cry. So remember, usually infants are probably gonna, if they're in pain, they're gonna be crying. What does that tell you? That tells you that they have a good airway. If a baby's crying, I'm happy about that. That means they got a good airway. If a baby's not crying or not making sound, that's probably a bad thing. So always remember that. Work of breathing increases as the body attempts to compensate for abnormalities in oxygenation and ventilation. May manifest as abnormal airway noise. Accessory muscle use, retractions, head bobbing, nasal flaring, tachypnea, and tripod position. Circulation to skin. When cardiac output fails, the body shunts blood from areas of lesser need to areas of greater need. Pallor of skin and mucous membranes may be seen in compensated shock. Modeling is a sign of poor perfusion. Cyanosis reflects decreased level of oxygen. From PAT findings, you will decide if the patient is stable or requires urgent care. Excuse me. If unstable, assess ABCs, treat life threats, and transport immediately. With life-threatening external hemorrhage, assess and address the CABs first, including tourniquets. If stable, continue with the remainder of the assessment process. Hands-on ABCs. For pediatric patient, you will now perform a hands-on ABCs assessment. Assess and treat any life threats as you identify them by following the ABCDE format. Airway, breathing, circulation, disability, exposure. Airway. If airway is open and will remain open, assess respiratory adequacy. If patient is unresponsive or has difficulty keeping airway open, ensure it is properly positioned and clear of mucus, vomitus, blood, and foreign bodies. Use head tilt chin lift or jaw thrust maneuver to open airway. Always position airway in neutral sniffing position. Keeps trachea from kinking, maintains proper alignment. Establish whether a patient can maintain his or her own airway. So when you're laying a patient flat, especially for children, when their head's a little bit bigger in proportion to their body, you're going to try and pad underneath the shoulders so the airway gets in line. The trachea is not kinked. So breathing, you use the look, listen, and feel technique. Place both hands on patient's chest to feel for rise and fall of chest wall. Belly breathing in infants is considered adequate. Bradyapnea is an ominous sign that indicates impending respiratory arrest. So usually when kids go into cardiac arrest, it's because of respiratory arrest. So always look out for any slow breathing. Circulation. Determine if patient has a pulse, is bleeding, or is in shock. In infants, palpate brachial or femoral pulse. In children older than 1 year, palpate carotid pulse. Strong central pulses usually indicate that the child is not hypotensive. Weak or absent peripheral pulses indicate decreased perfusion. Tachycardia may be an early sign of hypoxia. Interpret pulse with the context of overall history. The PAT and primary assessment. Evaluate trend of increasing or decreasing pulse rate. Feel skin for temperature and moisture. Estimate the capillary refill. Disability. Use APU scale or pediatric GCS. Check pupil response. Look for symmetric movement of extremities. Pain is present with most types of injuries. Assessment of pain must consider developmental age of patient. Exposure. Hands-on ABCs require that the caregiver remove some of the patient's clothing for observation. Avoid heat loss by covering the patient as soon as possible. More prone to hypothermic events. Should be kept warm during transport. Transport decision. Determine whether rapid transport to the hospital is indicated. Rapid transport indicated if significant MOI. History compatible with serious illness. Physical abnormality noted. Potentially serious anatomic abnormality. Significant pain. Abnormal level of consciousness. Also consider type of clinical problem. Benefits or ALS treatment in the field. Local EMS protocol. Your comfort level. Transport time to hospital. If patient's condition is urgent, initiate immediate transport to the closest appropriate facility. Less than 40 pounds, transport in a car seat. If you guys have it, we carry PD mates that'll attach to the gurney. Those are more for pediatrics. I think about under 10 pounds or so. So those are very helpful when we have pediatrics. To mount a car seat to a stretcher, put head of stretcher upright, put car seats against the back of stretcher. Secure upper and lower stretcher straps through seatbelt holes on car seat. Push sheet into stretcher tightly and retighten straps. Follow manufacturer's instructions. Secure car seat and captain's chair. Patients who require spinal mobilization immobilize on longboard or other suitable spinal mobilization device. Patient's cardiac arrest, use a device that can be secured to the stretcher. You should not use a pediatric patient's own car seat. The goal is to secure and protect the pediatric patient for transport in the ambulance. If the only time you're going to use their car seat if it's not damaged. If their car seat is damaged after an accident, you will not use that. You will put them on the gurney. Okay, history taken. Approach to history depends on age of patient. History information for an infant, toddler, or preschool-age child will be obtained from caregiver. Adolescent information is obtained from patient. Questioning the parents or child about the immediate illness or injury should be based on the child's chief complaint. Questions to ask based on chief complaint, NOI or MOI, length of sickness or injury, key events leading up to injury or illness, presence of fever, effects of illness or injury on behavior, patient's activity level, recent eating, drinking, and urine output. So a good thing also, has the patient been sick? Has the patient been getting fluids lately? Has the patient been having diarrhea? They might be dehydrated. They might have a fever. Changes in bowel or bladder habits, presence of vomiting, diarrhea, abdominal pain, presence of rashes. Obtain name and phone number of caregiver if they are not able to come to the hospital with you. Sample history. So same as adults. Remember, every patient gets sample history. Questions are based on age and developmental stage. Obtaining OPQRST. Same for children and adults. Questions based on age and developmental stage. Secondary assessment. Physical examinations. Secondary assessment of the entire body should be used when patient is unresponsive or has significant MOI. Use a DCAT BTLS mnemonic. Focus assessment should be performed on patients without life threats. Focus on areas of body affected by injury or illness, as well as on the chief complaint, MOI or NOI, and the findings of the primary assessment. Infants, toddlers, and preschool-age children should be assessed started at the feet and ending at the head. School-age children and adolescents should be assessed using the head-to-toe approach. Head, look for bruising, swelling, and hematomas. Assess fontanelles in infants. Nose, nasal congestion and mucus can cause respiratory distress. Gentle bulb or catheter suction may bring relief. Ears, drainage from ears may indicate skull fracture. Battle sign may indicate skull fracture, and presence of pus may indicate infection. Mouth, look for active bleeding, loose teeth. You want to make sure you clear the airway. Have your suction unit available. Note the smell of the breath. Neck, examine tracheal area for swelling or bruising. Note if patient cannot move neck and has high fever. This could be meningitis. You may need to put a mask on this patient, and put a mask on yourself as well. Chest, examine for penetrating trauma, lacerations, bruises, or rashes. Feels clavicles and every rib for tenderness and or deformity. Back, inspect back for lacerations, penetrating injuries, bruises, or rashes. Abdomen, inspect for distension. Gently palpate and watch for guarding or tensing of muscles. Note tenderness or masses. Look for seatbelt abrasions or bruising. Extremities, assess for symmetry. Compare both sides for color, warmth, size of joints, swelling, and tenderness. Put each joint through a full range of motion while watching the patient's eyes for signs of pain. Vital signs. Some guidelines equipment used to assess adult circulatory status have limitations in pediatric patients. Normal heart rate varies with age in pediatric patients. Blood pressure is usually not assessed in patients younger than 3 years. So at least just get a pulse rate, and then skin color too. Assessment of skin is a better indication of pediatric patient's circulatory status. When equipment is used, it is important to use appropriate size equipment. Use a cuff that covers 2/3 of the pediatric patient's upper arm. So either too small or too big is going to give you an inaccurate reading, and that goes along with everyone. Make sure the blood pressure cuff fits. Use this formula to determine blood pressure for children ages 1 to 10 years. 70 plus 2 times the child's age in years. It's going to be your systolic blood pressure. Respiratory rates may be difficult to interpret. Count respirations for at least 30 seconds and double that number. In infants and those younger than 3 years, evaluate respirations by assessing the rise and fall of the abdomen. So for assessing the systolic blood pressure, so 70 plus 2 times the child's age and year. So if you got a 5-year-old, it's 2 times 5, which would be 10 plus 70. So that'd be 80. So you're looking at a general guideline of 80 systolic. So anything higher than that is going to be good. And then anything lower than that, they might be considered hypotensive. Assess pulse rate by counting at least 1 minute, noting quality and regularity. Normal pediatric vital signs vary with age. Assess respirations, then pulse, then blood pressure. Evaluate pupils using a small pen light. Compare size of the pupils. Pulse oximetry is a valuable tool for patients with respiratory issues. So reassessment. Reassess pediatric patient's condition as necessary. Obtain vitals every 15 minutes if stable. Obtain vitals every 5 minutes if unstable. Continually monitor respiratory effort, skin color and condition, level of consciousness, or interactiveness. Interventions. Parents or caregivers may be able to assist. Able to calm and reassure child, often well versed on their child's medical conditions. Oxygen or nebulizer administration. Communication documentation. Communicate and document all relevant information to ED personnel. Respiratory emergencies and management. Respiratory problems are the leading cause of cardiopulmonary arrest in the pediatric population. Failure to recognize and treat will lead to death. Patient must work harder to breathe and will eventually go into respiratory failure if left untreated. In the early stages, you may note changes in behavior such as combativeness, restlessness, and anxiety. Signs and symptoms: increased work of breathing, nasal flaring, abnormal breath sounds, accessory muscle use, tripod position. As a pediatric patient progresses through possible respiratory failure, efforts to breathe decrease, chest rises less with inspiration, body has used up all available energy stores, and cannot continue to support extra work of breathing. Without care, cyanosis may develop. As the patient progresses to possible respiratory failure, changes in behavior, and eventually altered level of consciousness, patient may experience periods of apnea. Heart muscle becomes hypoxic, leads to bradycardia. If heart rate is slow, you must begin CPR. This is only for pediatric or newborns. If the heart rate is slow, you're going to begin CPR. As a patient progresses to possible respiratory failure, respiratory failure does not always indicate obstruction. Condition can progress from respiratory distress to failure at any time. Reassess frequently. A child or infant needs supplemental oxygen. For infants and children in possible respiratory failure, assist ventilation with BVM and 100% oxygen. Allow patient to remain in a comfortable position. Airway obstruction. Children can obstruct airway with any object they fit in their mouth. Causes of trauma: teeth may have been dislodged into the airway. Blood, vomitus, or other secretions can cause severe airway obstruction. Infections can cause obstruction. Infection should be considered if patient has congestion, fever, drooling, and cold symptoms. Croup is an infection in the airway below the level of the vocal cords. Epiglottitis is an infection of the soft tissue above the level of the vocal cords. So if you see a pediatric patient, if the mom or dad calls you and they're holding it up and they say that patient has a fever and it looks like they're having a hard time breathing and the patient is drooling, they most likely have epiglottitis. So it's going to swell and it's going to narrow the airway. This is something you can't fix out in the field. This is something as a paramedic I can't fix out in the field. They need to get to a hospital. Airway obstruction. Obstruction by foreign object may involve upper or lower airway. Obstruction may be partial or complete. Signs and symptoms associated with partial upper airway obstruction include decreased breath sounds and stridor. Infants or children with a complete airway obstruction will not make any sound, have no breath sounds, and become rapidly cyanotic. Signs and symptoms of lower airway obstruction include wheezing and or crackles. Best way to auscultate breath sounds in a pediatric patient is to listen to both sides of the chest at armpit level. So on the sides, on the flanks, you're going to listen. Immediately begin treatment of airway obstruction. Encourage coughing to clear airway when patient is conscious and forcibly coughing. If this does not remove the object, do not intervene except to provide oxygen. Allow patient to remain in whatever position is most comfortable. If you see signs of severe airway obstruction, attempt to clear the airway immediately. Ineffective cough, no sound, inability to speak or cry, increasing respiratory difficulty with stridor. Cyanosis, loss of consciousness. If infant is conscious with a complete airway obstruction, perform up to 5 back blows followed by chest thrusts. Position the infant face down on your forearm and slap the back forcefully 5 times. If the airway does not clear, flip the child onto his or her back and perform up to 5 chest thrusts in the same manner you would for CPR. Repeat the process until the obstruction clears or until the infant becomes unconscious. And then begin CPR. If a child is conscious with a complete airway obstruction, perform abdominal thrust, Heimlich maneuver, continue until the obstruction is relieved or until the child loses consciousness. So an easy way to do this is get down on one knee, have your knee in the patient's back and do a chest thrust, abdominal thrust, or the Heimlich maneuver to get that out. Use head tilt, chin lift, and finger sweep to remove a visible foreign body in an unconscious pediatric patient. Use chest compressions to relieve a severe airway obstruction in an unconscious pediatric patient. Increases pressure in chest, creating an artificial cough. Asthma, a condition in which the bronchioles become inflamed, swell, and produce excessive mucus, leading to difficulty breathing. A true emergency is if not promptly identified and treated. 10% of U.S. children are affected. Common causes for asthma attack include upper respiratory infection, exercise, exposure to cold air or smoke, and emotional stress. Signs and symptoms. Wheezing as patient exhales. In some cases, airway is completely blocked and no air movement is heard. Cyanosis and respiratory arrest may quickly develop. Tripod position allows for easier breathing. Treatment. Allow patient to assume a position of comfort. So let them tell you what's the best way for them to get air. And let them assume that position of comfort. Administer supplemental oxygen, a bronchodilator via meter dose inhaler with a spacer mask device if protocol allows. If assisting ventilations, use slow, gentle breaths. Resist temptation to squeeze back hard and fast. A prolonged asthma attack may progress into status asthmaticus. A true emergency. Administer oxygen and provide rapid transport. Patient becomes exhausted and stops struggling to breathe. Manage airway aggressively. Administer oxygen and transport promptly. Consider ALS support. So pneumonia, leading cause of death in children. It's also a big cause of death in geriatrics as well. Pneumonia is a general term that refers to an infection to the lungs, often a secondary infection. It can also occur from chemical ingestion. Diseases causing immunodeficiency in children increase risk. Incidence is greatest during fall and winter months. So when cold season comes around, this is why a lot more people are getting their flu shots to reduce the risk of flu and possible pneumonia. So presentation of pediatric patient, unusual rapid breathing, sometimes with grunting or wheezing sounds, nasal flaring, tachypnea, hypothermia or fever, unilateral diminished breath sounds or crackles over the infected lung segments. Pediatric patient treatment. Primary treatment will be supportive, monitor airway and breathing status, administer supplemental oxygen if required. If the child is wheezing, administer a bronchodilator if permitted. Diagnosis of pneumonia must be confirmed in the hospital. Croup, an infection of the airway below the level of the vocal cords, usually caused by a virus, typically seen in children between ages 6 months and 3 years. Easily passed with children. The disease starts with a cold, cough, and a low-grade fever that develops over 2 days. The hallmark signs of croup are stridor and a seal bark cough. So that's probably going to be a test question for you guys. Make sure you know what a seal bark cough indicates. Treatment. Croup often responds well to the administration of humidified oxygen. Bronchodilators are not indicated for croup and can make the child worse. Epiglottitis, bacterial infection of the soft tissue in the area above the vocal cords. Incidence decreased since development of vaccine. Epiglottitis can swell to 2 or 3 times normal size. So especially when children, they have smaller airways. If the epiglottitis swells even a little bit, it could cause an airway obstruction, a partial airway obstruction, or a total airway obstruction. Children look ill, report a very sore throat, and have a high fever. Tripod position and drooling. So remember, drooling, high fever, tripod position, it's probably epiglottitis. Bronchiolitis, specific viral illness of newborns and toddlers, often caused by RSV or respiratory syncytial virus, causes inflammation of the bronchioles. RSV is highly contagious and spread through coughing or sneezing. Virus can survive on surfaces. Virus tends to spread rapidly through schools, and in child daycare centers. More common in premature infants and results in copious secretion. Occurs during the first 2 years of life, more common in males. Most widespread in winter and early spring. Bronchioles become inflamed, swell, and fill with mucus. Airways can easily become blocked. Look for signs of dehydration, shortness of breath, and fever. Treatment. Use calm demeanor when approaching. Allow patient to remain in position of comfort. Treat airway and breathing problems. Humidified oxygen is helpful. Consider ALS backup. Pertussis, whooping cough, is caused by bacterium spread via respiratory droplets, less common in the United States. Signs and symptoms: coughing, sneezing, and a runny nose. Coughing becomes more severe with distinctive whoop sound during inspiration. Infants may develop pneumonia or respiratory failure. To treat pediatric patients, keep the airway patent and transport. Pertussis is a contagious, so follow standard precautions, including wearing a mask and eye protection. Airway adjuncts, devices that help to maintain the airway or assist in providing artificial ventilation, including oropharyngeal and nasopharyngeal airways, bite blocks, and BVMs. OPAs, keeps tongue from blocking airway and makes suctioning easier. Should be used for pediatric patients who are unconscious and in respiratory failure. Should not be used in conscious patients or those who have a gag reflex or who may have ingested a caustic or petroleum-based product. Nasopharyngeal airway, usually well tolerated, used for responsive pediatric patients, used in association with possible respiratory failure. Rarely used in infants younger than 1 year. Should not be used if there is a nasal obstruction or head trauma. Nasopharyngeal airway, potential problems: may become obstructed by mucus, blood, vomitus, or the soft tissues of the pharynx. May stimulate the vagus nerve and slow the heart rate or enter the esophagus, causing gastric distension. May cause a spasm of the larynx and result in vomiting if inserted into a responsive patient. Should not be used when pediatric patients have facial trauma because the airway may tear soft tissues and cause bleeding into the airway. Oxygen delivery devices, several options for pediatric patients and also for adults. You guys should all know this by now. Blow-by oxygen at 6 liters a minute provides more than 21% oxygen concentration. Nasal cannula 1 to 6, non-rebreather 10 to 5, and BVM at 10 to 15 liters per minute. BVM is the highest form of oxygen concentration, provides nearly 100%. Non-rebreather provides up to 95, and it gets lower and lower. Non-rebreathing mask, nasal cannula, or simple face mask is indicated for pediatric patients who have adequate respirations and or tidal volumes. The BVM is used for those with respirations less than 12 breaths a minute or more than 60 breaths a minute, an altered LOC or inadequate tidal volume. Blow-by method, less effective than face mask or nasal cannula for oxygen delivery, does not provide high oxygen concentration. Administration: place tube through hole in bottom of cup. Connect tubing to an oxygen source at 6 liters a minute. Hold cup 1 to 2 inches away from nose and mouth. Nasal cannula. Some patients prefer the nasal cannula, some find it uncomfortable. Applying a nasal cannula, choose appropriately sized. Connect tubing to an oxygen source at 1 to 6 liters a minute. I would not go higher than 4 liters on a nasal cannula. 6 liters might be a little too much. They might be getting a little too much air in their nose, and it's going to make it even more uncomfortable. So I think this is a form of blow-by oxygen because it's got it going through the cup, and mom's just holding it up for the kid because the kid's probably not going to tolerate a mask or a nasal cannula. So non-rebreathing mask delivers up to 90% oxygen and allows patient to exhale all carbon dioxide without rebreathing it. Applying a non-rebreathing mask, select appropriately sized mask, connect tubing to oxygen source at 10 to 15 liters a minute. Adjust oxygen flow as needed. Bag valve mask. Indicated in patients with too fast or too slow respirations, who are unresponsive, or who do not respond to painful stimuli. Assisting ventilations with BVM, select appropriately sized equipment. Maintain a good seal with the mask on the face. Ventilate at the appropriate rate and volume using a slow, gentle squeeze. So a 2-person BVM ventilation, similar to 1-person BVM ventilation, except one rescuer holds a mask to the face and maintains the head position. Usually more effective in maintaining a tight seal. CPR, cardiac arrest in pediatric patients associated with respiratory failure and arrest. Children are affected differently by decreasing oxygen concentration. Adults become hypoxic and the heart develops a dysrhythmia that leads to sudden cardiac arrest or cardiac death. Children become hypoxic and their hearts slow down, becoming more bradycardic. Shock. So a condition that develops when the circulatory system is unable to deliver a sufficient amount of blood to the organs. It results in organ failure and eventually cardiopulmonary arrest. Compensated shock is the early stage of shock. Decompensated shock is the later stage of shock. Common causes include trauma injury with blood loss, especially abdominal, dehydration from diarrhea or vomiting, severe infection, neurologic injury, such as severe head trauma. So with anybody who's complaining of diarrhea or vomiting, or has been sick, you want to make sure that to ask if they've been drinking fluids as well. It's caused dehydration and electrolyte imbalance, sodium imbalance. They might need an IV to get some fluids back in them. Severe allergic reaction, anaphylaxis to an allergen, insect bite or food allergy, diseases of the heart, collapsed lung, tension pneumothorax, blood or fluid around the heart, cardiac tamponade, pericarditis. Pediatric patients respond differently than adults to fluid loss. They may respond by increasing heart rate, increasing respirations, and showing signs of pale or blue skin. Signs of shock in children: tachycardia, poor capillary refill time, greater than 2 seconds. Mental status changes. Treat shock by assessing ABCs, intervening as required. The order becomes CAB if there's an obvious life-threatening external hemorrhage or if cardiac arrest is suspected. So compressions, airway breathing. Pediatric patients do not demonstrate a fall in blood pressure until shock is severe. So pediatric patients go downhill really quickly. So be aware. Constantly monitor your patient who's been involved in a traumatic event. Treatment. In assessing circulation, assess the rate and quality of pulses, the temperature and moisture of hands and feet, skin color, and capillary refill time, with 2 seconds being normal. Changes in pulse rate, color, skin signs, and capillary refill time suggest shock. Blood pressure is the most difficult vital sign to measure. Assessment should also include talking with the parents or caregivers. Limit your management to simple interventions. Do not waste time performing field procedures. Ensure airway is open. Prepare for artificial ventilation. Control bleeding. Give supplemental oxygen by mask or blow-by. Continue to monitor airway and breathing. Position the pediatric patient in a position of comfort. Keep warm with blankets and heat. Provide immediate transport. Contact ALS backup as needed. Anaphylaxis, a life-threatening allergic reaction that involves generalized multi-system response, characterized by airway swelling and dilation of blood vessels. Common causes are insect sting, medications, or food allergy. Anaphylaxis, signs and symptoms, hypoperfusion, stridor and or wheezing, increased work of breathing, altered appearance, restlessness, agitation, sometimes a sense of impending doom. Hives as well. Treatment, maintain airway and administer oxygen. Allow caregiver to assist in positioning the patient, oxygen delivery and maintaining calm. Assist with epi, auto-injector based on protocol, and provide rapid transport. So bleeding disorders. Hemophilia is a congenital condition in which patients lack normal clotting factors. Most forms are hereditary and severe, predominantly found in male population. Bleeding may occur spontaneously. All injuries become serious because blood does not clot. So any minor injuries with these patients who has a history of hemophilia, you're going to encourage them to go to the hospital and get checked out because it's hard to see internal bleeding. So altered mental status, abnormal neurologic state, understanding developmental changes and listening to caregiver's opinion are key. AEIU tips reflects major causes of AMS. So remember, we've gone over this. Any ALOC patient, you want to go through AEIU tips to rule everything out. So signs and symptoms vary from simple confusion to coma. Management focus on ABCs and transport. If level of consciousness is low, patient may not be able to protect airway. Ensure patent airway and adequate breathing through non-breathing mask or BBM. Transport to the hospital. Seizures, result of disorganized electrical activity in the brain, manifest in a variety of ways. Subtle in infants with abnormal gaze, sucking and or bicycling motions. More obvious in older children with repetitive muscle contractions and unresponsiveness. So common causes of seizures, have all these common causes down here. You don't diagnose in the field, have them be seen by a physician, have them transported. Once seizure stops and muscles relax, it is referred to as postictal state. The longer and more intense the seizures are, the longer it will take for this imbalance to correct itself. Postictal state is over once normal level of consciousness is regained. Status epilepticus, seizures that continue every few minutes without regaining consciousness in between or last longer than 30 minutes. Recurring or prolonged seizures should be considered life-threatening. Patient does not regain consciousness or continues to seize, protect him or her from harming himself and call for ALS backup. Management, securing and protecting airway are priority. Position head to open airway, clear mouth with suction. Use recovery position if patient is vomiting. Provide 100% oxygen by non-rebreathing mask or blow-by method. Begin BVM ventilations if no signs of improvement. Some caregivers will have given the child a rectal dose of diazepam prior to your arrival. Monitor breathing, level of consciousness carefully. Transport to the appropriate facility. So diazepam is a seizure med. It's usually given rectally for pediatric patients. Meningitis, inflammation of tissue that covers the spinal cord and brain caused by infection by bacteria, viruses, fungi, or parasites, left untreated, can lead to brain damage or death. Being able to recognize a pediatric patient with meningitis is an important skill to have. Individuals at greater risk, males, newborn infants, compromised immune system by AIDS or cancer, history of brain, spinal cord, back surgery, children who've had head trauma, children with shunts, pins, or other foreign bodies in their brain or spinal cord, especially children with VP shunts. Signs and symptoms vary with age. Fever and ALOC changes can range from mild headache to inability to interact appropriately. Child may experience seizure. Infants younger than 2 to 3 months can have apnea, cyanosis, fever, distinct high-pitched cry, or hypothermia. Meningeal irritation or meningeal signs are terms to describe pain that accompanies movement, often results in a characteristic stiff neck. In an infant, increasing irritability and a bulging fontanelle without crying. Neisseria meningitis is a bacterium that causes rapid onset of meningitis symptoms, often leads to shock and death. Children present with small pinpoint cherry red spots or larger purple-black rash. Serious risk of sepsis, shock, and death. So this is some signs of your rash. And a patient also complains of fever and stiff neck. It's possible they have meningitis, so we're going to throw a mask over them and throw a mask over yourself as well. Protect yourself. Patients with suspected meningitis should be considered contagious. Use standard precautions. Follow up to learn the patient's diagnosis. This is to protect yourself. So the patient is diagnosed with meningitis. You also want to get tested for yourself and probably start on some medications. Treatment: provide supplemental oxygen and assist with ventilations if needed. Reassess vital signs frequently. GI emergencies and management: never take a complaint of abdominal pain lightly. Monitor for signs and symptoms of shock. Complaints of gastrointestinal origin are common in pediatric patients. Ingestion of certain foods or unknown substance. In most cases, patient will be experiencing abdominal discomfort with nausea, vomiting, diarrhea. Can cause dehydration. Appendicitis is also common. If untreated, can lead to peritonitis or shock. Will typically present with fever and pain upon palpation of right lower quadrant. Rebound tenderness is a common sign. If you suspect appendicitis, promptly transport to the hospital for evaluation. Obtain a thorough history from the primary caregiver. How many wet diapers today? Is a child tolerating liquids and keeping them down? How many times has a child had diarrhea and for how long? Are tears present during crying? Poisoning emergencies and management, common among children, can occur by ingesting, inhaling, injecting, or observing toxic substances. Common sources: alcohol, aspirin, acetaminophen, cosmetics, household cleanup products, and houseplants. Iron, prescription medications of family members, illicit street drugs, vitamins. Signs and symptoms vary depending on a substance, age, and weight. May appear normal, confused, sleepy, or unconscious. Some substances only take one pill to be lethal. Be alert for signs of abuse. After primary assessment, ask the caregiver the following: what is the substance involved? Approximately how much was ingested? What time did the incident occur? Any change of behavior or level of consciousness? Any choking or coughing after the exposure? Make sure you take the bottle or whatever the substance came in with you to the hospital so the doctor could look at it. You could also call poison control as well and see what they say about any signs or symptoms you should be looking out for. Contact poison control for assistance. Treatment: perform external decontamination, remove tablets or fragments from mouth, wash or brush poison from skin. Assess and maintain ABCs and monitor breathing. If shock is present, treat and transport. Give activated charcoal according to medical control or local protocol. Activated charcoal. This is one medication you guys can give. Remember the dose you guys are allowed to give. Not recommended for those who have ingested acid, and alkali, or petroleum product. Not recommended for patients who have a decreased level of consciousness. Common trade names are Instachar, Actidose, and Liquichar. Usual dose is 1 gram per kilo body weight. Pediatric dose is 12.5 to 25 grams. And that's a bottle. A bottle usually comes in 25 grams. So just go ahead and give that whole bottle depending on your protocol, if that's within the hour. Dehydration emergencies and management occurs when fluid loss is greater than fluid intake. Vomiting, diarrhea are common causes. Can lead to shock and death if left untreated. Infants and children are greater risk. Life-threatening dehydration can overcome an infant in a matter of hours. Can be mild, moderate, or severe. Mild dehydration signs: dry lips and gums, decreased saliva and wet diapers. Moderate dehydration signs: Sunken eyes, sleepiness, irritability, loose skin, sunken fontanelles, severe dehydration signs, mottled, cool, clammy skin, delayed CRT, increased respiration. Treatment. Assess ABCs and obtain vital signs. If severe ALS backup may be necessary for IV access. Transport to ED. So to test the patient's dehydrated, you could pinch the patient's skin. I don't know if I'd pinch it back here, but you could pinch the forearm up like that. And if the patient's skin kind of pops up like a tent, kind of stays there and then goes back down, that's a sign of dehydration. It's called tenting. So fever emergencies management, an increase in body temperature, 100.4 Fahrenheit or higher is abnormal, rarely life-threatening, causes infection, status epilepticus, cancer, drug ingestion, aspirin. So anything above 100.4 can be considered on that sepsis level, especially for adults. So we want to be aware of that. So arthritis, systemic lupus, higher environmental and temperature, result of internal body mechanism in which heat generation is increased and heat loss is decreased. Accurate body temperature is important for pediatric patients. Rectal temperature is most accurate for infants and toddlers. Under tongue or arm will work for older children. Patient may present with signs of respiratory distress, shock, a stiff neck, a rash, hot skin, flushed cheeks, and in infants, bulging fontanelles. Assess for nausea, vomiting, diarrhea. Decrease feedings and headache. Transport and manage ABCs. Follow standard precautions with communicable diseases. So febrile seizures, common between 6 months and 6 years, caused by fever alone, typically occur on first day of febrile illness. Characterized by tonic-clonic activity, lasts less than 15 minutes with little or no postictal state. May be a sign of more serious problem. Assess ABCs, provide cooling measures with tepid water, and provide prompt transport. All patients with febrile seizures need to be seen in the hospital setting. During emergencies and management, take steps to ensure your own safety. Second most common cause of unintentional death among children. Children younger than age 5 are at most serious risk. Alcohol frequently a factor with adolescents. Principal condition is lack of oxygen. A few minutes without oxygen affects the heart, lungs, and brain. Hypothermia from submergent and icy water. Diving increases the risk of neck and spinal cord injuries. Signs and symptoms: coughing and choking, airway obstruction, difficulty breathing, AMS, and seizure activity. Unresponsiveness: fast, slow, or no pulse. Pale cyanotic skin, abdominal distension due to the water getting in the lungs and down in the stomach. Management: assess and manage ABCs. Contact ALS crew to intervene if needed. Administer 100% oxygen. Apply cervical collar if trauma is suspected. Perform CPR in unresponsive patient and cardiopulmonary arrest. Pediatric trauma emergencies and management. #1 killer of children in the U.S. Quality of care can impact recovery. The muscles and bones of children continue to grow well into adolescence. Fracture of the femur is rare. Source of major blood loss. Older children and adolescents are prone to long bone fractures. Physical difference: children are smaller than adults. Locations of injuries may be different. Children's bones and soft tissues are less well developed than adults. The force of injury affects structures differently. A child's head is proportionally larger than an adult's and exerts greater stress on the neck structures during a deceleration injury. Psychological differences. Psychologic differences often injured because of underdeveloped judgment and lack of experience. Always assume the child has serious head and neck injuries. Injury patterns. Important for EMT to understand physical and psychologic characteristics of children. Vehicle collisions. Children can dart out in front of motor vehicles without looking. Typically sustain high energy injuries to the head, spine, abdomen, pelvis, or legs. Sport injuries. Children are often injured in organized sports activities. Head and neck injuries can occur in contact sports such as football, wrestling, ice hockey, field hockey, soccer, or lacrosse. Remember to mobilize cervical spine. Be familiar with protocols for helmet removal. Injury to specific body systems. Head injuries, common in children because of the size of the head in relation to the body. Infant has softer, thinner skull, may result in brain injury. Scalp and facial vessels may cause a great deal of blood loss if not controlled. Nausea and vomiting are common signs and symptoms of head injury in children, easy mistake for abdominal injury or illness. Should suspect a serious head injury in any child who experiences nausea and vomiting after a traumatic event. Mobilization, necessary for all children with possible head or spinal injuries after a traumatic event. Mobilization can be difficult because of the child's body proportions. Younger children require padding under the torso to maintain a neutral position. May be necessary to immobilize a child in a car seat. Around 8 to 10 years of age, children are no longer require padding under the torso and can lie supine on the backboard. Padding will be required along the sides to properly secure the child on an adult-sized backboard. Chest injuries usually result of blunt trauma. Chest wall flexibility in children can produce a flailed chest. Maybe injuries within the chest, even though there may be no sign of external injury. Pediatric patients are managed in the same way as adults. Abdominal injuries, common in children. Children can compensate for blood loss better than adults. Children can have a serious injury without early external evidence of a problem. Monitor all children for signs of shock. Signs of shock are evident. Prevent hypothermia with blankets. So greater than 25% blood volume loss significantly increases risk of shock. Remember, younger kids, pediatrics are going to have a lower, a longer compensatory mechanism. They're going to be able to compensate for a long time, and then they're going to go downhill really quickly. So past this 75%, almost to the 75%, it's going to increase your risk of shock. Okay, and then greater than 30 to 40% volume loss significantly increases rise of shock. Burns to children are considered more serious than burns to adults, have more surface area relative to total body mass, which means greater fluid and heat loss. Do not tolerate burns as well as adults, more likely to go into shock, develop hypothermia, and experience airway problems. Common ways that children are burned: exposure to hot substances, hot items on a stove, exposure to caustic substances. Infection is a common problem. Burned skin cannot resist infection as effectively. Sterile techniques should be used when handling skin. Should consider child abuse in any burn situation. Report any information about suspicions. You guys are mandatory reporters, remember. You're going to have to report to the hospital any suspicions you might have, any child abuse. Severity, minor, moderate, and critical. Pediatric patients are managed in the same manner as adults. Prevent hypothermia if shock is suspected. Patient shows bradycardia, ventilate, monitor the patient during transport. Injuries to the extremities. Children have immature bones with active growth centers. Growth of long bones occurs from the ends at specialized growth plates. Potential weak spots. Incomplete or green stick fractures can occur. Generally, extreme injuries in children are managed in the same manner as adults. Painful, deformed limbs with evidence of broken bones should be splinted. Should not attempt to use adult immobilization devices on pediatric patients. We have special boards. We have special pediatric boards that we carry. Try and not put a pediatric patient on an adult backboard. Try and get your pediatric board out if you have one. Pain management. First step is recognizing the patient is in pain. Look for visual clues and use the Wong-Baker Faces Pain Scale. Interventions are limited to positioning, ice packs, and extremity elevation. Will decrease pain and swelling to injury site. ALS interventions may be needed. Another important tool is kindness and providing emotional support. Disaster management. Jumpstart triage system intended for patients younger than age 8 years and weighing less than 100 pounds. 4 triage categories: green, yellow, red, and black. Green, minor, not in need of immediate treatment, able to walk except in infants. Yellow, delayed treatment, presence of spontaneous breathing with peripheral pulse, responsive to painful stimuli. Red, immediate response, apnea, responsive to positioning or rescue breathing. Respiratory failure, breathing but without a pulse or inappropriate painful response. Black, deceased or expectant deceased. Apneic without a pulse or apneic and unresponsive to rescue breathing. So you're going to go and look at this jumpstart triage table. Okay. So remember what we talked about this. So if you get a busload of kids that were injured in an accident, first thing you're going to do is get on board, and then everyone will walk outside and walk to the side of the road. All those people are probably going to be green right there. And then airway, I want to make sure the patient has airway. I want to make sure that they're breathing. I want to make sure that good circulation. Anybody who's not breathing, has no pulse, you're going to tag them black and move on. Patient has semi injuries, semi bad injuries, probably going to tag them yellow. And then any immediate injuries, any severe injuries are going to be tagged red. Child abuse and neglect, any improper or excessive action that injures or otherwise harms a child, includes physical abuse, sexual abuse, neglect, and emotional abuse. Over 500,000 children are victims of sexual abuse annually. Many children suffer life-threatening injuries. If abuse is not reported, it is likely to happen again. Signs of abuse. You will be called to homes because of a reported injury to a child. Child abuse occurs in every socioeconomic status. Be aware of patient's surroundings. Document findings objectively. Ask yourself the following. Injury typical for age of child. MOI reported consistent with the injury. So this is a big one. If you get a call, say an adult call because their child fell and they landed on their arm's broken, but then you notice other areas of their body that may have old bruising, or deformities that don't look like they just happened. That's not consistent with somebody falling just recently. That's something that could be possible child abuse right there. Caregiver behaving appropriately. Evidence of drinking or drug use at the scene. Delay in seeking care for the child. Like I said, so any older bruising that you notice, they might not want to report it because they might get it investigated. Good relationship between child and caregiver or patient. So usually child will not want to be pulled away from their caregiver. If a patient does not cry or scream or ask to go back to their caregiver, that might be a good sign that there's not a great relationship, possible abuse going on. Are there multiple injuries at different stages of healing? Any unusual marks of bruising that may have been caused by cigarettes, grids, or branding injuries? Are there several types of injuries? Any burns on hands or feet that involved a glove distribution? Is there unexplained decreased level of consciousness? Is a child clean and an appropriate weight for his or her age? Is there any rectal or vaginal bleeding? What does a home look like? Clean or dirty, warm or cold? Is there food? Child abuse mnemonic may help. You guys could go over this table. So bruises, observe color and location. New bruises are pink or red. Over time turn blue, then green, then yellow, brown, and fade. Bruises to the back, buttocks, or face are suspicious and usually infected by a person. Burns to the penis, testicles, vagina, or buttocks are usually inflicted by someone else. Burns that look like a glove are usually inflicted by someone else. You should suspect child abuse if the child has cigarette burns or grid patterns. Fractures. Fractures of the humerus or femur do not normally occur without major trauma. Falls from bed are not usually associated with fractures. Maintain an index of suspicion if an infant or young child sustains a femur fracture. A complete fracture of the bone indicates that the child was exposed to a great deal of traumatic force. Shaken baby syndrome. Infants may sustain life-threatening head trauma by being shaken or struck. Bleeding within the head and damage to the cervical spine. Infant will be found unconscious, often without evidence of external trauma. Shaking tears blood vessels in the brain, resulting in bleeding around the brain. Pressure from the blood results in an increase in cranial pressure, leading to coma and or death. Neglect, refusal or failure to provide life necessities. Examples are water, clothing, shelter, personal hygiene, medicine, comfort, and personal safety. Symptoms and other indicators of abuse. Abused children may appear withdrawn, fearful, or hostile. Should be concerned if a child does not want to discuss how an injury occurred. Parent may reveal a history of accidents. Be alert for conflicting stories or a lack of concern. Abuser may be a parent, caregiver, relative, or friend of the family. EMTs in all states must report suspected abuse. Remember, you guys are mandatory reporters. There's forms you guys have to fill out. In some states, most states do have special forms. Supervisors are generally forbidden to interfere with the reporting. Law enforcement and child protection services will determine whether there is abuse. It's not your job. It's your job to report it. Not your job to determine if there is abuse. Sexual abuse. Children of any age and gender can be victims of sexual abuse, maintain a high index of suspicion, often long-standing abuse by relatives. Assessment. Limited to determining type of dressing required. Treat bruises and fractures as well. Do not examine genitalia unless there is evidence of bleeding or other injury. Do not allow a child to wash, urinate, or defecate until a physician completes examination. Difficult but important step to preserve evidence. Ensure an EMT or police officer of the same gender remains with the child. Maintain professional composure. Assume a caring, concerned approach. Shield the child from onlookers. Obtain as much information as possible from the child and any witnesses. Transport all children who are victims of sexual assault. Sexual abuse is a crime. Cooperate with law enforcement officials in their investigations. So, sudden infant death syndrome. Unexplained death after complete autopsy. About 3,500 infants die of SIDS annually. Baby should be placed on his or her back on a firm mattress in a crib free of bumpers, blankets, and toys. Baby should sleep in the same room, but not the same bed, chair, or sofa as an adult. This is impossible to predict. You guys might run on these in your career. Hopefully not. But it does happen occasionally. Risk factors. Mother younger than age 20 years. Mother smoked during pregnancy. Low birth weight can occur at any time of day. You're faced with 3 tasks. Assessment of the scene. Assessment and management of patient. Communication and support of the family. Patient assessment and management. Victim of SIDS will be pale or blue, not breathing and unresponsive. Other causes include overwhelming infection, child abuse, airway obstruction, meningitis. Accidental or intentional poisoning, hypoglycemia, congenital metabolic effects. Begin with ABC assessment. Provide necessary interventions. Depending on how much time has passed, patients may show post-mortem changes, rigor mortis, or dependent lividity. If you see these signs, call medical control. If no signs of post-mortem changes, begin CPR. So know your local protocols. Know when you are supposed to pronounce in the field, and know when you are supposed to begin CPR. If you have any questions about a particular call, you could always call medical control. As you assess patient, pay special attention to any marks or bruises on the child before performing any procedures. Note any interventions that were performed before your arrival. Scene assessment. Remember, carefully inspect environment, noting condition of scene and where infant was found. Assessment should concentrate on signs of illness, general condition of the house, signs of poor hygiene, family interaction, a site where the infant was discovered. Communication and support of the family. Sudden death of an infant is devastating for a family. Tends to evoke strong emotional responses among healthcare providers. Allow the family to express their grief. Lend a listening ear. After the call, we have what's called a SISM team, where we have people that go through training. And you call them at any time of the day and just talk to them about the call, about your feelings, about whatever it is on your mind on that call. We see things out in this field that nobody should have to see in their life, but it's part of the job. Calls like these are never easy. most likely you'll be pulled off the rest of your shift, and you'll have to go to a SISM meeting with everyone else who's on that call. Kind of just decompress and talk about stuff. So, death of a child. In addition to medical treatment, the child may require you must provide the family with empathy and understanding. The family may want you to initiate resuscitation efforts, which may or may not conflict with your EMS protocols. Introduce yourself to the child's parents or caregivers and ask about the child's date of birth and medical history. Do not speculate on the cause of the child's death. The family should be asked whether they want to hold the child and say goodbye. The following interventions are helpful. Use the child's name. Speak to family members at eye level. Use died and dead instead of passed away or gone. So anytime you're dealing with any death in the field, these terms you want to stay away from. Passed away, gone. You don't want to get those terms lost in translation. You have to be honest with them. You have to tell them exactly what's going on. You have to be, I'm not sure what the right word is, but firm on what happened. Your son, your dad, your mom, your grandpa, they died. Don't use passed away, because people sometimes think that they have a chance or there's hope. So try and stay away from those terms. Acknowledge family's feelings, but never say I know how you feel. Often to call other family members or clergy. Keep any instructions short, simple, and basic. Ask family members if they want to hold the child. Wrap the child in a blanket and stay with the family while they hold the child. Do not try to remove equipment that was used in attempted resuscitation. Everyone expresses grief in a different way. Some will require intervention. Many caregivers feel directly responsible for the death of a child. Some EMS systems arrange for home visits after a child's death for closure. You need training for these visits. Child's death can be very stressful. Take time before going back to the job. Talk with other EMS colleagues. Be alert for signs of post-traumatic stress in yourself and others. Consider the need for help if signs occur. There's so many programs available to us as first responders that help us with any and all situations almost. And it's important to reach out if you think you need help or if you think someone needs help. It's a good thing to reach out. Apparent life-threatening event. Infants who are not breathing, cyanotic, and unresponsive sometimes resume breathing and color with stimulation. Apparent life-threatening event, or ALT. Classic ALT is characterized by a distinct change in muscle tone, choking, or gagging. After ALT, child may appear healthy and show no signs of illness or distress. Must complete careful assessment and provide rapid transport to the ED. Pay strict attention to airway management. Assess infant's history and environment. Allow caregivers to ride in the back of the ambulance. Physicians will determine the cause. So how does pediatric anatomy differ from adult anatomy? Remember, what are the different ways that pediatric body is different than an adult? So D, there are several important anatomic differences between pediatric patients and adult patients. The head, specifically occiput, is proportionally larger. Their tongue and epiglottis are also proportionally larger, and the epiglottis is floppier and more omega-shaped. Child's airway is narrower at all levels, and the trachea is less rigid and easily collapsed. When a small child falls from a significant height, the most often strikes the ground first. So remember, what's normally going to be the biggest part, most heaviest part of the child. So A, compared to adults, pediatric patients have proportionally larger heads when they fall from a significant height. Gravity usually takes them head first. This is why head trauma is the most common cause of traumatic death in a pediatric patient. When assessing a conscious and alert 9-year-old child, you should So B, a 9-year-old child is capable of answering your questions. By allowing a child to answer your questions, you can gain his or her trust and build a good rapport, which facilitates further assessment and treatment. Do not isolate the child from his or her parent, yet do not allow the parent to do all the talking unless the child is unable to communicate. When assessing any patient, you should place yourself at or slightly below the patient's eye level. This position is less intimidating and helps to minimize patient anxiety. Purpose of a shunt is to VP shunt, simply called. A shunt is a tube that extends from the ventricles cavities of the brain to the peritoneal cavity. VP shunts are used to drain excess fluid from the brain, thus preventing increased pressure within the skull. Which of the following statements regarding febrile seizures is correct? So D, febrile seizures are the most common seizures in pediatric patients. They are common between the ages of 6 months and 6 years of age. Most pediatric seizures are due to fever alone, hence the name febrile seizure. However, seizures and fever may indicate a more serious underlying condition such as meningitis. Febrile seizures are characterized by generalized tonic-clonic activity and last less than 15 minutes. If a postictal phase occurs, it is generally very short. You respond to a sick child late at night. The child appears very ill, has a high fever, and is drooling. He's sitting in tripod position, struggling to breathe. You should suspect. Remember the different signs and symptoms of the different diseases that we talked about. And what's the serious one you can't fix out in the field? So C, this child has all the classic signs of epiglottitis, high fever, drooling, and severe respiratory distress. Epiglottitis is a potentially life-threatening bacterial infection that causes the epiglottitis to swell rapidly and potentially obstruct the airway. Treatment for a semi-conscious child who swallowed an unknown quantity of pills. It includes look at what the question is asking. Look for any key words. So B, if a semi or unconscious child has ingested pills, poison, or any type of harmful substance, closely observe for vomiting, give high flow oxygen, assist ventilation if necessary, rapidly transport to the ER. Do not give activated charcoal to any patient who is not conscious and alert enough to swallow. Induction of vomiting is not indicated for anyone regardless of age. When you're using the mnemonic child abuse to assess a child for signs of abuse, you should call that the D stands for So A, the mnemonic child abuse stands for consistency of the injury with the child's developmental age, history inconsistent with the injury, inappropriate parental concerns, lack of supervision, delay in seeking care, effect, bruises of varying stages, unusual injury patterns, suspicious circumstances, and environmental clues. Delay in care may happen when the parent or caregiver does not want the abuse noted by other people. So a 4-year-old girl fell from a second-story balcony and landed on her head. She is unresponsive, has slow, irregular breathing, has a large hematoma to the top of her head, and is bleeding from her nose. You should So C, the child has a severe head injury and is not breathing adequately. You must manually stabilize her head to protect her spine, open her airway with the jaw thrust maneuver, suction her airway if needed, insert an OPA, and assist her ventilation with a bag valve mask. A full body scan is performed after you have performed a primary assessment to detect and correct any life threats. The MPA airway is contraindicated for this child. She has a head injury and is bleeding from the nose. So the AVPU scale is used to monitor a patient's level of consciousness. What does the P stand for? You guys should all know this by now. C, the P in the AVPU scale stands for painful. The patient is responsive to pain. They should withdraw from it.